Surgery. We broadcast all of our spine surgeries here at the Duke Spine Institute, as we've been doing for 7.5 years. Every surgery that we do is broadcast live over the internet for 7.5 years without missing a single surgery. We do this for education of the public. It's free. Our broadcasts are always free. They're always over the internet. They're streamed live on Facebook and YouTube and Periscope. We encourage our viewers to ask questions during the surgery. And we broadcast all types of spine surgeries, including fusions that we do, laser endoscopic surgeries, even carpal tunnel syndrome. Anything spine or nerve related. If you have a request for a spine surgery, let us know. Post it in the comments. There is a calendar as well on our website that you can go to look and see what surgeries are coming up so you can plan accordingly. Our surgeries are typically done on Tuesdays or Thursdays, and some weeks we have a couple, other weeks we have more. It just depends on the patient flow. The coronavirus has certainly affected patients' ability to travel and come in and get surgery done. So we're getting ready to do a 4-level Duke laser disc repair. This patient has herniated discs at L2-3, L3-4, L4-5, L5-S1. His pain in his back is in the L2-3, L3-4, L4-5, L5-S1 region. And I believe it's coming from those 4 discs. He has annular tears in the back of the discs at each level. He has a small herniation at each level. It's actually a small to medium size. And he has right-sided leg pain. He's been keen to get rid of his back and leg pain. He found out about the Duke laser disc repair. He did not want fusion surgery. His fusion surgery would have been quite extensive. All right, we're going to get started without further ado. I'm heading into the operating room. You'll be able to watch us stream live as I do this surgery. Of course, our patients are awake for the lumbar Duke laser disc repair in the beginning, so I'll be talking to him. You're welcome to ask questions, type questions, and we'll do our best to answer them for you. Maybe we can show the MRI. So just give us a minute to have my team cover up the patient name.
I'm not sure about this slide. Maybe someone you can help. This slide or somebody because the live I'm not sure.
You cannot.
Yeah,
what you? Wait. Let's just think about this.
I don't know about the line of view of the camera.
Yeah, move it out here. Move it all the way over here, out of the way. All right, Sean, we're going to cover the name, and then if you can have the camera go and look at the MRI in a moment. Wait till we cover everything up, and then we'll show the audience this patient's MRI. Yep, I see it. Hi, I'm Dr. Duke Machen. And I look big because I'm wearing lead. I'm actually a skinny man. We wear a lot of lead in the operating room to protect us from radiation. If you're anywhere within 6 feet of the X-ray machine emitter, you're potentially going to get radiation. All right, are you guys ready? So let's go ahead and show everyone the MRI. You can see, where's my hand? Oh well. All right, so that MRI is showing you, let me come over there. We don't always do this, but sometimes we do. I'll need to just point some stuff out. Okay, this is the L5-S1 disc right here, and there's the L4-5, L3-4, L2-3. Even L1-2 has a small herniation. This patient's pain starts here and travels in this whole area in his back. You see the little bright area right there? That's an annular tear at L5-S1. and there's a bulging disc. This patient has annular tear with disc bulge at 4 levels, and I believe his pain is coming from all 4 levels. We're going to verify that shortly. All right, let's come back to the operative field. Remember, if you have questions, feel free to type them up. I'm going to talk to my patient for a moment. Are you ready, sir? Dr. Duke Majin here. We're going to get started, okay? All right. Now, the first thing I'm going to do is give you a little numbing medicine, okay, in the skin. So you feel probably a little stick and burn. That's normal. Don't get excited about it. Just lay still, okay? If it's hurting you, just tell me ouch, and I'll give you some more medicine. Now, you're going to feel a little stick and burn. That's normal. So I'm going to probably have to do one incision for L4551, maybe L34, and then a second incision further up. You okay? So let's see if I can get up there. Normally I can do the whole surgery with one incision, but when you're doing 4 discs, you need probably two incisions for that. I'll try to do what I can, but I don't think I can get all 4 with one incision. I already talked to the patient about that. He's aware. I've injected 7 mils of numbing medicine, and we'll get started. Start at 5-1 and 4-5. Are you comfortable, sir? Remember our deal, okay? If you're uncomfortable for any reason, say ouch, and that's a cue for me to give you some more numbing medicine, okay? So, first step is to place the needles transforaminal. Shot. Looking good. And put a little numbing medicine on the fascia. The other place that bothers patients is the facet joint. Go lateral, please. The facet joint obviously has innervation. That's why people have facet joint pain. The facet joints are in the back of the spine. There's paired joints, one on the right, one on the left, at each vertebral segment. All right, that's really good, nice, but I need to see the sacrum. So a little bit south, maybe an inch. That's good. Let's see what we've got. All right, there's the sacrum. It's beautiful. Now we got to get the end plates lined up at L5 and S1. We're not far off, but you can see a double shadow on the pedicle of L5. Go ahead. There's no point in navigating your needle until you get a true lateral at the disc you're trying to get into. I need you to move and take a picture, okay? And you're taking too long. That's actually better, but we got way too much sacrum. Let's go north, please. All right. So just for the future, I always start at L5-S1 if I'm doing L5-S1. So just be prepared to have that level ready to rock and roll first. All right, let me have some WAG. Shot. We need about a degree there. Lock it in. That's perfect. Can do a little orbit, but I think we're okay. All right, that's exactly where we need to be. Okay. Shot. Yeah, a little high. Shot. Remember our deal, okay? Shot. You let me know if it's uncomfortable for you, okay? Sir? Shot. It's looking a little bit better. Are you awake? How are you doing so far? Shot? Good? All right. Shot? So I'm heading towards the L5-S1 disc through the foramen. Shot? I'm pretty much there. Any pain? Shot? Give me an AP. So I want to verify my position on anterior posterior view. We're lined up pretty good with the disc. AP view looks great. I'm right at the disc on the AP view, back to a lateral. So you can see the spinous process there of L5 and the sacrum. It's a little bit rotated further up. Are you comfortable? Shot? Shot? Any discomfort? Let's go to 4-5. So I would start with a WAG. You're not far off on 4-5, as a matter of fact. We're very close. It may actually be more of an orbit than a WAG. So let's start with an orbit. Let's give it a degree or two, one way or than the other. Go ahead. It looks worse. Shot. I'm not sure. I think that actually is even worse. It's hard to tell. Let's go back the other way. Yeah, it's definitely better right there. That's probably as good as we're going to get it. Lock it in. Beautiful. So we've got a really nice view of L4-5. I'm going to make the incision. Now, for those of you who watched the first surgery, we did a 4mm incision, 4 millimeters. This surgery requires a 7mm incision. So 4 millimeters for the neck, 7 for the back. Shot. Shot. He's doing really well. The patient is. He's very comfortable. Shot. Are you you doing okay? Okay, you're doing, everything's going well back here. I appreciate your patience. Shot. 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 You feel anything? Huh? All I want to know if it's back or leg. Down the leg.
We have a question.
Where? It doesn't shoot down the leg, right? Shouldn't. Well, I can't hear what he says. Just verify it doesn't go down your leg. Nice. Perfect. Give me an AP. Yes, I'll take the question.
One of our viewers on Facebook is wondering, I hear you say WAG when you're taking shots. What does that mean?
Yeah, so great question. WAG, I'm talking to my X-ray technician who's got the fluoroscope. That's perfect. Go back to a lateral. And WAG means changing the orientation of the X-ray beam. Basically, it's a lateral view. We're shooting the beam through the patient's body from side to side. And what I want is I want the beam to be parallel to the disc. I want it to be parallel to the disc. And obviously, you know, because the discs are sometimes a little bit of scoliosis, they may not be exactly parallel to the beam of the X-ray machine. So rather than have the patient move their body a little bit, we just move the X-ray machine. And WAG means moving one side up north towards the head or down south towards the feet. Okay. All right, I'm going to try to go a little bit further north. Shot. So. Shot. That's better. Shot. Yep. I like that. Shot. Shot. I kind of feel the herniation there. That's perfect. going through the herniation. I just went through it. And I felt the annular tear and the herniation. We're going to try to do the next disc. I need to see, yeah, maybe a little bit of wag and then maybe some moving your feet north. So you guys watching? Sean, what does the view look like? We don't have it. You're doing great, sir.
The
Oh, yeah,
fluoroscopic
that's
view
good
looks
right
fine.
there. View looks good?
Yes.
So Luis, put your hands like this, okay? So our viewers can see, like, pretend that between Luis's hands is the disc, okay? That's the disc. So what WAG does is when we shoot, ooh. Sean, are you not paying attention? All right, so let's pretend we're shooting an x-ray, right? If the x-ray beam goes like this, it cuts across the disc, it's not parallel to the disc, it cuts across the disc, that's bad. It gives us the wrong orientation of the spine. We don't know where the true left and right sides of the spine are, where the facets are, where the disc is. So what we need is the x-ray beam to be lined up exactly parallel with the axis of the disc space. That way we get a true lateral view through the disc. And that's what I use to navigate the needle, okay? That's what WAG does. It changes the orientation of the x-ray beam so it goes right through the disc space perfectly. Hopefully that helps. Shot. You doing all right, Shot? Is that a yes? Uh-huh. I may want to do the second incision now, but I'm going to try one last time to access from this disc, from this incision, I mean. That's not bad. Right there. Shot. On the facet. Shot. Shot. All right. You're doing great. We're almost done, I promise you. Shot. We're almost done to where we can put you to sleep. Okay. Shot. 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 All right. You kind of see a little bone spur off the end plate there at 3-4. Shot. Is that bothering you? Yeah, that's one of your bad discs, and I'm through the tear. So we got 3 out of 4 done. We got one more to go. I might be able to do them all through one incision. I might. Don't count me out. Maybe asking too much. Shot? Huh? That's it? Oh, that would be interesting. I don't think I've ever done 4 discs through one incision. We did it one time? Okay. So you're saying that I should be able to do it again? Is that what you're saying?
Yes.
Huh? There's the expectation that I can get 4 discs with one incision. I'm going to make it an 8mm incision right now. And because it's L2-3, I'm going to go medial. I'm going to go medial. Medial means towards the midline in medicine. So the higher up you go, the more medial you want to be. Shot. It's too low. Shot. Shot. Can redirect a little bit, but not that much. Shot. It's pretty darn close. Shot. 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 I think we're I'm going to take a separate incision. Though the angle, trajectory of angle looks not bad. Try one more time. Shot. Shot. It's probably right on the transverse process. I need to be above it. So let's not yet. Let's do a little num just to be sure. We're going to have to do another incision just above. No. Start with the needle. The transverse process of let's see, 5, 4, 3 is the one getting in the way. So you need to be a little higher. Shot. Are you still comfortable? We're almost done with the torture. So our patient is awake, for those of you wondering. We do these beginning of the surgery. The patient needs to be awake to help me, to make sure I'm not too close to any shot vital structures like nerves. And then shot. Once we get to the disc, where do you feel that? Where? How far down? How far down? The bottom of the butt? No, that's not the leg. That's the facet. That's referred pain from your facet joint, believe it or not. That's people who have facet joint pain do get pain down there. Shot? So we're good. We're good. We're not anywhere near your nerve root. Shot? We're almost at the last disc, okay? You're doing fantastic. Shot? Let's do an AP. You're doing great. Yeah. All right. It's not bad. And the lateral was right there. Where's the lateral? I see it. Okay. All right, let's go back to a lateral view, please. Blood pressure good. Let's get it down a little. Let me know when you've got it down. Well, you want to wait? Is that what it is for the propofol? Huh? Is that what you'd prefer to do? If that's what you're waiting for, it's probably okay to wait. Shot? Are you comfortable, sir? Yes? Shot? All right, we're definitely in the disc. Okay, I'll need him awake for just a few more minutes. Are you comfortable? Have you watched these surgeries? How many did you watch? 4 or 5. What do you think about them? I didn't understand them. You're going to have to tell me. You know, we should probably put a mic on the patients. Sean? Process improvement. Let's mic up our patients or put a mic next to their mouth. All right? Sean,
Loud and clear.
talk to Sonny and let's get it done. I think it'd be good. I mean, we don't want to hear the moans and groans, but for the responses, it's good. So you watched several of these. What happens next? Not quite. You're missing a step. All right. Is that your typical pain? Huh? Is that where you typically get pain? On a scale of 1 to 10, how bad was that? A 9 out of 10, L2-3, concordant. All right, you did good. We found one of your bad discs. That was the top one. But it definitely needs to be fixed. So folks, we're doing a test right now. When patients come to me in clinic and they have an MRI showing some bad discs and they're complaining about pain, you know, I want to know that before I do surgery on their disc and do the Duke laser disc repair, I want to know that that disc is causing their pain. Most of the time I can figure it out based on the location of the pain. And like I said, his pain was from up here, from about L2 down to S1. So here's L2. Let's have a marker.
Yes.
Sterile, obviously. So if you want to look at things here, the L5-S1 disc is right around here, okay? L5-S1. The L4-5 disc is right about here. This is the 4-5, L4-5. And then the L3-4 disc is right around here, L3-4. We're having some fun doing some drawing on your back, okay? And then all in the name of education, then L2-3, all right? So we just did a discogram at L2-3. The light needs to be moved a little bit, just a little. No. Wait. Turn on the other lights. The roof. All right. There we go. That's nice. Okay, so these are his discs, all right? Now, if he was having fusion surgery, the incision would be from here down to here. Look at the size of that incision. Why does it need to be bigger than the disc? Because we have to get wide enough to put screws in. Don't worry, you're not going to wake up with screws, all right? So this is the normal fusion incision. If this patient wanted a fusion, this is how big it would be. That's like 12 inches, okay? That's huge. And it's very painful surgery. So if we're doing laser surgery through, there's going to be 2 little cuts, 7 millimeters each, actually 8 and 7, and we're going to fix these discs. But we're testing the discs. This one here, L2-3, was positive. It was a 9 out of 10. You all see that? 9, okay? Now we're going to, unfortunately, test another one. How bad is that on a scale of 1 to 10? Huh? 10. So this 3-4 we just tested is a 10. 10 out of 10 pain. Pretty cool. I'm sorry. I don't enjoy this part of the surgery, I promise you, but it's extremely elucidating and very important, and it tells us that these discs are definitely causing your pain, which means when you wake up, that pain will be gone for the rest of your life, as long as you don't mess your back up, okay? We call this part of the surgery a discogram, evocative discogram, because we're actually testing his herniated discs to see if they really are the source of his pain, because there's no point in me fixing a herniated disc that doesn't cause pain. How bad is that on a scale of 1 to 10? 9? He said a 9. So another 9. By the way, these are your winning lottery numbers. You like that, huh? All right. Sorry, we're having a little fun, but we're not laughing at you. We're just enjoying our time with you here. We're just about ready to put him to sleep. Normally we we've probably had about 5 mils of blood loss, 5 cc's. Normally we don't because the blood pressure's down a little, and we're going to get his blood pressure down in just a minute. We've already tested 3 out of 4 discs, and I think all of them are going to be painful. Shot? How bad is that? 7? Is that where you typically get pain? Yeah, all right. Well, that's Luis's phone number, 79109. All right, you can go to sleep. When you wake up, all that pain will be gone. Won't that be nice? All right. Count from 1 to 100 out loud for me. Yeah, you feel a little burn in your arm. That's just the medicine going in. Shot. We're going to start with L2-S1. I always start with L2-S1. It's just, I'm a creature of habit. Nice and loud. Count from 1 to 100. In Italian, please. Did you stay at a Holiday Inn Express? You're doing great. If you get to 100, we don't pay the anesthesiologist for today. All right, so this patient, surgery will take an hour, 15 minutes a disc at this point, and he'll be having pizza this afternoon with us for lunch. It takes an hour to recover from the surgery. If anyone else in the world was doing this surgery, they'd be doing fusions. They would have to fuse 4 discs. Now, how many spine surgeons would do that? There's almost none in the world that will do that. There's a few, including myself. I'm not afraid to do multiple level fusions, but most spine surgeons, they fuse 1 disc at a time. So let's say they would have fused L2-S1. They would have gotten rid of the 7 out of 10 pain, but the patient would have had 9 out of 10, 10 out of 10, and 9 out of 10 pain at the disc they didn't fuse. Why do spine surgeons not fuse 4 discs at a time? The reason is simple. It takes too much time. It would take them 20 hours, the average spine surgeon, to do a 4-level TLIF. All right, so it takes them too long. There's too much blood loss. The patient would bleed to death on the table for most spine surgeons. At Duke Spine Institute, we do 4-level fusions, not often, rarely. And it takes me about 5 hours to do the surgery. I would clean out each disc. I would put a cage in each one, and then I would put screws and rods from L2 to S1. That's not what we're doing today. This patient didn't want fusion. He wanted laser surgery. And you're going to see the laser surgery. We're going to fix all 4 discs in an hour, and the patient's going to go home an hour later and be back to work tomorrow. This is the only place in the world you can get the Duke laser disc repair surgery. What's different about this surgery is the fact that I'm repairing the annular tear. Spine surgeons don't know about the annular tear. They don't understand it. They don't realize the annular tear is the source of back pain. But at Duke Spine Institute, we do. We figured it out 16 years ago, and we published on it. And so I've been doing annular debridements to repair the annular tear for 16 years. We've had 0 complications to date. 0 complications in over 1,300 surgeries I've done. This is March 4th, 2021, okay? Shot? All right, so we're in the foramen. By the way, he does have short pedicles. Short pedicles means congenital spinal stenosis. He has short pedicles. His spine holes are narrow to begin with. He was born that way. All right, I can't advance it by my hand anymore, so I'm going to go. Now, don't be alarmed that we're using a hammer. We use hammers all the time in healthcare and medicine. It's normal for us to do that in spine surgery. The reason why we broadcast these surgeries is so people like you can watch and see what we actually do in surgery. Okay? It's kind of cool to see what surgeons do. That's one of the reasons I became a surgeon. I liked to watch what we do on the human body to fix it. But I also like to fix it myself, so I don't like to watch too much. I tell my kids, don't watch too much videos. Do. Don't watch, do. The best way to learn something is to do it. Now, obviously, I don't want you doing this surgery at home in your garage. Right? I'm not advocating for you to do this surgery without the proper training. You need the training. And you can't learn how to do this surgery by watching my videos. You need You can learn a little bit, but you can't learn everything. So don't try to do this surgery without proper training. Okay? We're inside the disc at L2-S1. Patient is asleep. Oh, it's caught. No, shot. I don't want to bring both out. I'm trying to remove the dilator without removing the tubular retractor. No, I've grabbed it well. It's just that I can't, I have to stop the tube from moving. See that? That's moving.
We have a couple questions.
You get to see us troubleshoot a little bit. I'm going to bring the dilator in further.
Maybe I can grab the...
No. I'll take the question in a moment. Shot? All right, that was good. Sometimes a little piece of disc material gets caught in there, and it just gets wedged between the dilator and the tubular retractor, and that's what happened. Okie dokie. Done. Whew. Someone wipe the sweat off my forehead, please. I'm kidding. I haven't exerted myself that much yet. And by the way, surgery should be fun. You know, when you're good at what you do, it should always be enjoyable. All right, we have a question from our audience. I just need to line this up first, and then I'm ready. Hold on, I can't see. I see, there's the black mark. Any way they can intensify that mark? Not you.
Oh.
The company that does our repairs. See it right there?
I can ask him, yeah.
It's just getting a little faded. Okay. So who has a question?
So our first question comes from a viewer on YouTube who's wondering,
The answer is
so
yes.
is the Duke laser disc repair a good alternative to
I'll marry you.
TLIF, even if my doctor's told me TLIF is my only option?
Sean, unfortunately I can't hear your voice. I need you to turn the volume up a little bit.
How's this?
Better. Much better.
Okay, so our viewer on YouTube is wondering, is this surgery a good alternative to TLIF, even if my doctor's told me TLIF is my only option?
Oh, this is such a beautiful question. So one of our viewers, who's our viewer?
His name is Brian.
All right, and where are they watching from?
YouTube.
YouTube. So one of our YouTube viewers is asking, my doctor said I need a TLIF. That's my only option. TLIF is a transforaminal lumbar inner body fusion. It's a fusion, and it's a specific way of doing the fusion. There's probably 10 different ways of doing it, doing the fusion. Okay, so when we talk about lumbar fusion, there's probably at least 10 different reasonable variations to do the fusion. This is one of those variations. Okay, ultimately fusion means for two bones to fuse together or grow together. So there are many different ways to do fusions on the spine. You can go through the front, through the side, through the back. You can go obliquely or straight through the back. So a TLIF is just one type of fusion. And it's the one that I do when I do fusions. I go transforaminal. As a matter of fact, right now we are going transforaminal with this tube. So we're doing a transforaminal Duke laser disc repair, not a transforaminal lumbar fusion. Now I am in the inner body space, so I'm exactly where your fusion would be. And we're repairing the annular tear and getting rid of this patient's pain as a result of repairing the tear. So to answer your question, no, a TLIF is not the only option for you. The surgery you're watching right now would be a vastly better option because you wouldn't be in the hospital. This is outpatient in our surgery center in Florida. The surgery takes an hour versus a TLIF, which would take many hours. The surgery is done without complications to date, whereas TLIFs have many complications like infection, loosening of the hardware, breaking of the hardware, failure of fusion, migration of the implants, and adjacent segment disease, among all types of other complications. And this surgery here is done almost bloodless, whereas a TLIF is you're going to lose a lot of blood. This surgery here is done without postoperative pain meds, just muscle relaxer and some anti-inflammatory. That's it. Whereas a fusion, TLIF, you're going to require lots of pain medication, narcotics for a long time. This surgery is 1 day, you go back to work. A TLIF, you're going to be out of work for probably 6 weeks to 3 months on average. So this is a better option for you if you're considering lumbar fusion of any type, whether it's a TLIF or an ALIF or an XLIF, whatever it is. The Duke laser disc repair is the best alternative. He's waking up and moving around, so he's uncomfortable. Yeah, I need him to relax a bit. Let me know when you're ready. Okay. By the way, our patient does not have a tube down. They're under sedation, propofol sedation, and that's why I'm telling my anesthesiologist, because when you're doing twilight propofol sedation, just lay still, everything is okay. Yeah, you gotta not let him wake up that much. But basically, whenever you do sedation surgeries like this, you want to have the patient balanced between just sleepy enough, but not too sleepy. And the reason is if a patient gets too sleepy, then they can stop breathing. Now, I've never had a patient that has had any kind of problems from the sedation, but when they get a little too light, like this patient was just a minute ago, you just have to give them a little bit more medicine to put them to sleep. So it's the anesthesiologist is titrating. It's called titration. They're titrating the amount of propofol this patient is getting. Now, propofol is the very best for this kind of surgery. Patients wake up after surgery, they feel like $1,000,000. They don't feel groggy and crappy like you do after general anesthesia with gas. Plus, you don't get any of the complications you can get with gas anesthesia. So, much better type of surgery. All right, this is the tear that was causing his pain. And by the way, this is the same tear causing our viewer on YouTube who is asking about, do I need TLIF surgery? The answer is no. This is what you need right here. And we can do it outpatient for you in an hour, and you go home an hour later. There's no hospital stay. Nobody wants to go to the hospital right now because of COVID. Unfortunately, hospitals are sources of infection. I hate to say it, but it's true. There's a special name for infections that you get at the hospital. Anybody know that name? Oh my gosh, we got superstars here. I heard it in stereo. Nosocomial. Nosocomial. N-O-S-O-C-O-M-I-A-L. A nosocomial infection is an infection that a patient gets while they're at the hospital. And usually they get it from something at the hospital. Most of the time that something is another patient and their secretions that they've gotten onto a patient, who then those secretions contain bacteria or viruses, and they cause an infection. So this patient is not at the hospital. Stand by. We are in our surgery center at Duke Spine Institute, and we've had 0 infections here in 7.5 years we've been open. So you get to avoid infection. With TLIF, there's at least a 5% chance of getting an infection. That's 1 in 20. And if you get an infection in your spine, it is a life-altering event. You know, you're never going to be normal again, and the infection will definitely cause scar tissue to form, and so you don't want that. So this surgery is the alternative to spinal fusion, folks. I don't want you to think for one moment that I personally don't do spinal fusions, because I do. As a matter of fact, I was brought up on spinal fusions. I was trained at the University of Florida in Gainesville with some of the best spinal fusion surgeons in the world. Dr. Rick Fessler and Dr. Glenn Rectine, Dr. Mike McMillan. These are pioneers of spinal fusion. I'll tell you another one, Dr. Jacob, but he's a piece of garbage. Yeah, Pat, I hope you're listening. And, I mean, literally a piece of garbage of a human being. I don't even want to mention his name, except that it's true. He trained me to a degree. And then, of course, the most important spine surgeon that trained me was Dr. Jeffrey Henn. Jeff Henn was special because he was a great person, kind, caring, empathetic. He took great care of patients. He understood his role in medicine. He was there for the patients, not himself. And extremely well dedicated, intelligent, very well trained. He trained at the Barrow Neurological Institute. The Barrow Neurological Institute was considered one of the top spine surgery training program, if not, probably the top spine surgery training program in the United States, neurosurgically. He was trained by Curtis Dickman, Volkner Sontag, among others. These are two giants in spine surgery. So I got my early training and residency in from 1997 to 2004 by some of the best spine surgeons in the world. And I learned how to do really good, standard, typical spine surgeries, including artificial discs, fusions, laminectomies, microdiscectomies, correction of deformities, osteotomies, et cetera, so on and so forth. A-lifts, T-lifts, X-lifts, everything. Okay, so I was born and bred as a state-of-the-art, cutting-edge, great result, fusion spine surgeon. However, when I got done with my training, I found out about endoscopic surgery from a source, a friend, and they turned me on to this surgery, but it wasn't being done in the States. It was only being done by one doctor in the States, and his name was Dr. Anthony Young, Tony Young. And Dr. Young took me in and trained me, but not until after I already went overseas and trained overseas with the South Koreans who were doing this type of similar types of endoscopic surgery. Not the same. So, of course, I learned major surgery, fusions, decompressions, reconstructions first, and that's what I did for many, many years. Over thousands of spinal fusions, thousands, and with really some of the best results in the world in terms of outcomes for patients, with great relief of pain and very few complications, and very few infections. That said, my infection rate, my first few years, was probably about 2%. 2 in 100 would get an infection. And then I started using vancomycin topically for my posterior surgeries. That's your T-lifts and your PCDFs. Any kind of surgery done through with an incision in the back where the muscles are. And once I started using topical vancomycin, I never had infections again. We would once in a while get a local red man syndrome. If we used too much vancomycin, the skin would turn red and blotchy and kind of maculopapular rash. It's called red man syndrome. Skin gets red. I mean, that's probably politically incorrect right now to say that, but that's what it's called. So, long story short, I cut back on the vancomycin dose. Now we use 1 gram topically for lumbar T-lifts. We use half a gram for PCDFs. And we don't really have the red man syndrome anymore. We certainly haven't had any infections either. So when I do fusion surgery, I do use antibiotics in the wound to minimize the risk of infection. Not every surgeon does. Many surgeons don't know about it. And when I say surgeons don't know about it, you can't expect your surgeon to know everything. I don't know everything about neurosurgery. There's lots I don't know. But my focus has been on spine surgery. And I do know a lot about spine surgery. As a matter of fact, there's probably nothing I don't know how to do. I may not do those surgeries. For example, I haven't done an odontoid fracture fixation in years, but I know how to do it. I've done them, many of them in my training. It's fairly easy for me to do, but if you have a type 2 odontoid fracture that's unstable, and the surgery you need where you put a screw into the odontoid, I know how to do that, but I don't do it very often because I don't do much trauma. I don't do much acute trauma, okay? I don't work at a trauma center where you're seeing motor vehicle accidents with odontoid fracture patients coming in every day. So I do mostly degenerative spine problems like herniated disc, bulging disc, degenerated disc, spinal stenosis, radiculopathy, myelopathy. So these are the bread and butter spine surgeries. These are the most common problems people have out in the public, in the community. People don't have type 2 odontoid fractures. It's just rare. So I deal with the most common types of spine injuries in my practice at Duke Spine Institute. We treat everyday back pain, neck pain, thoracic pain, leg pain, arm pain from pinched nerves. Okay? So don't think for one moment that I'm just an endoscopic spine surgeon. Those of you who have watched my surgeries over the last 7.5 years, which they've all been broadcast, you know that I do fusion surgeries as well. So I'm not trying to talk to you from the perspective of a doctor who doesn't know how to do fusion surgery. I'm talking to you from the perspective of a consummated spine surgeon who knows how to do everything in spine. And I'm telling you, this surgery right now you're watching is the very best of everything that's being done in the world today. That's why I do it. Because I can do it, and because it works. And it's far better than a fusion. A T-lift, an A-lift, an X-lift, an O-lift, any kind of fusion surgery, this is better. The patients go home an hour later. There have never been a complication for this surgery, ever. It's a tiny incision. It's easy to heal up from. There's no narcotic painkillers. There's no being laid up at home in bed for weeks. It is an amazing recovery surgery, and we're just about done with the bottom disc. Okay? So we got 3 more to go. All right, there's a little fat from the epidural space. We're leaving that alone. And then the epidural space is right there. That's where the herniation was, in that pit. It's gone. So I'm done here. We're going to take this tube out. By the way, you can see the end plate right there. Let's see. It's at 3 o'clock right there. That pinkish thing is the bone. The other end plate is over here at 9 o'clock. And the annular tear was right here, and I just debrided it. So I may have to take a little of this actually just to get more medial for a second. So this is the scope that was repaired, Luis.
Yes, sir.
It looks amazing.
Good.
Yeah, perfect picture. I could sharpen it up a little. I guess I didn't sharpen it there. That's better. Does that look better to you, Sean?
Yeah, a little bit.
Yeah.
We do have several other questions as well.
All right, standby laser. We're done here. Yes, I will take the questions.
So we have another viewer from Periscope who's wondering, if I've already had a microdiscectomy but I'm still experiencing pain, can this surgery be an option?
Oh, it's a great question. Sean, you could probably answer these questions yourself, right? So anyone in the world that has had any spine surgery done, whether it's a microdiscectomy, laminectomy, anything, this surgery will definitely help you if you're still having pain. Because microdiscectomies are not done for back pain. They're done for leg pain. All the surgeon's doing is unpinching the nerve that's getting pinched with a microdiscectomy. Does that make sense? So microdiscectomies are not done to fix back pain. If you have back pain, you should not have a microdiscectomy. You should have this surgery. This surgery fixes back pain and leg pain, leg symptoms. Okay? It does both. Microdiscectomy only treats leg symptoms. And a microdiscectomy is only done for herniations that are crushing the nerve. It turns out that 95% of people with leg pain from an irritated nerve root, it comes from nerve root irritation, not crushing the nerve root. So if you look at the MRI, the nerve root's not being crushed. The herniation may be next to the nerve root, touching it, but it's not crushing it. And yet the patients have horrible pain down the leg, sciatica. That's because the herniation is actually irritating the covering over the nerve as the nerve travels down the leg. It's covering called the dura, D-U-R-A, dura. And it's a white membrane that covers the nerve, and it has pain fibers in it. So when your dura is being irritated, you can feel it because you have nerve fibers inside the dura itself. So what I'm getting at is a microdiscectomy is not a surgery for back pain. It is only a surgery for crushed nerves. And crushed nerves only represent 5% of people with sciatica. The other 95% of people have irritation of the nerve without crushing, which is a problem because there's lots and lots of people out there with back and leg pain from irritation of the nerve but not crushing the nerve. And they go to the doctor and the surgeon says, the disc herniation's small. You don't need surgery. Just learn to live with it. Wait till you get weakness before you come back. And these poor people are out there, easy to fix with this surgery, the Duke laser disc repair, literally an hour procedure. And they would be totally normal after this surgery. And the other surgeons are just ignoring them because they don't see a crushed nerve. They just see a bulging disc. So that's why we really want people to understand a bulging disc is an annular tear with some nuclear material pushed out. And that bulging disc can definitely cause back pain and leg pain. So if your surgeon tells you, you know, get lost, there's nothing I can do to help you, I don't know what's wrong with you, go find some pain management, go do some therapy, go do acupuncture, and those don't work, come to Duke Spine Institute. We'll fix it for you. So yes, to answer your question, microdiscectomy, back pain you still have, this surgery will get rid of that pain. Because a microdiscectomy doesn't fix the annular tear. That's why. And you need your annular tear debrided so that it will heal properly and not be inflamed anymore. The reason you're having back pain is you have inflammation in your annular tear. Shot? We're done with L2-S1. Now we move to L4-5. That's next on the docket. Shot? So if people are wondering, are we still operating because during COVID? The answer is 100% yes. Okay? We're not shutting down, and we're not denying people treatment because of COVID. Okay? Obviously, if you have COVID and you want to come here, don't. Wait till it's gone. Wait till you're done. But if you are healthy and you want to get fixed and you're worried, you can come here. We'll take care of you. We'll fix your back. We'll fix your neck. Shot? All right, so this, look at the herniated disc back there. You can see the wire going through it is bulging out. It's still got some dye, and this is L4-5. You'll see the dilator tip in just a moment on the x-ray. Shot? You'll see it right now. See it? All right, so the tip of that pencil-like thing on the right, I'm going to bring it right through the foramen, transforaminal, at L4-5. Shot? And it's almost touching the herniation. You see that? It's just in the foramen right now. And the nerve root is coming out just above the wire and the dilator. All right, now, shot. Good. I can actually feel, shot, resistance right here. So you're seeing an outline of the herniation, but that's only one layer of the herniation. That's the inner layer. There's actually more of it stuffed out against the tip of the dilator where I'm at. I can feel the resistance right now. So the outline is not the full herniation, it's just the inside of the herniation. The rest of it is at the tip of my dilator. Yep, we're inside the tear, and we're going to fix that tear so that it'll heal itself properly. This is L4-5. This disc, remember, was a 9 out of 10. We wrote it down for you so you can all see it. 9 out of 10 pain. Shot. So when if you were to add up all the pain numbers and do a calculation, this is probably about 25% of his back pain, this disc. So imagine if we didn't fix it. He would still have back pain from this disc. Okay? I'll make this point one more time. Most spine surgeons you go to will fix one disc at a time. That's about 95% of spine surgeons. One disc at a time. That means you're still going to have untreated discs that are causing your pain. You're going to be back for a second surgery, a third surgery, and a fourth surgery. At Duke Spine Institute, we don't believe in making people have to have 4 surgeries. We want to fix you one and done. That's our philosophy. I'm the founder. I made it our philosophy. Maybe when I'm dead and gone, somebody will change what we do. I hope not. But I hope the people that come behind me, after me, will remember my teaching, which is you should always try to fix everything for the patient so that they go home pain-free, not one disc at a time. Laser Spine Institute used to do one disc at a time. Bonatti Institute, I can't really say anything, but you can imagine what I'm about to say. I'm not going to say it because I don't want to get a lawsuit from them. They're watching us all the time, trying to copy us. But basically, microspine, same thing. These other companies, they don't have anywhere near the caliber of work we do here at Duke Spine Institute. They don't have the results we have, and they don't have the lack of complications we have. All right. Other questions, Sean?
Yes, let me see here. So we have a question from a viewer on Facebook who's wondering, if you had a patient that needed both cervical and lumbar laser surgery, would you be able to do it all in one day? And if not, how far apart?
So if we had a patient with cervical that needed cervical and lumbar surgery, could we do it all in one day? The answer is yes, typically we could. I used to not like to do that, but I'm open to doing it only because we've done it and it's working and it's not causing any issues. Can you take the fluoro out, please? All right. So the answer is yes, but it also depends on how many discs we're talking about. If you're talking about 1 or 2 in each area, cervical and lumbar, it's not a problem. If you're talking about 4 in each area, then yes, that could be a problem. If I had my preference, I would rather do the surgeries on different days. And if you want to know what's absolutely the safest, probably of 3 days minimum between them, maybe 2 or 3 days between them, like 48 hours to recover. Luis, are you kidding me? I don't know. Get that fluoro out of the way, please. You have one job, and that's it. All right. Okay, it was probably just an air bubble. But it looked like the lens had shifted. No. Of course, no. I don't want it to, but it looked like it had. But I think it's just schmutz on the end of the screen, of the lens. Take it. Let me just adjust the focus for a second. So, I hope that answer will suffice. But 2 days, I would say 2 days. So if you're going to come here and have surgery on Tuesday, then your second surgery on Thursday, that would work. I think that's plenty enough time. So you'd be here a week total if you're going to fly in. By the way, about half of our patients fly in from other states, other countries, because this surgery is not available in other countries. It's available here in Melbourne, Florida. As a matter of fact, I was on the phone with a potential patient coming, and she's actually in Melbourne, Florida. I said, sorry, Melbourne, Australia. I apologize. I said, where are you from? She said, Melbourne, Australia. And I said, oh, we're in Melbourne, Florida. I said, you guys copied our name, right? No, actually, I think Melbourne, Florida copied Melbourne, Australia's name, if anything. So maybe somebody who settled here many years ago really liked Melbourne, Australia. This is the Space Coast of the United States that we're in. Duke Spine Institute is located in the Space Coast near Orlando, Florida. We're on the East Coast next to NASA. We're in the closest city to NASA, basically. Okay. Well, there's the tear right there. See the white? The white is the annular fibers. The blue is the nuclear material that's squeezed out from the center of the disc. And notice how this tear is right up against the end plate. And this is your L4 end plate right there. It's right below the laser. You can kind of see a little bit right there, the pinkish color. So this tear of the annulus is low. It's low. It's not in the middle of the disc, it's low. It's at the bottom of the disc. Some tears are higher, some are lower. This one is like a tear right off the end plate. And then the jelly squeezed out through there. So at least that's what it is here. Everybody's tears are a little bit different. We were talking about this earlier, like could the tear cause the modic changes? The answer is yes. The tear could cause the modic changes. There's a big herniation piece right there. You see that? Let's grab it out. That's the nuclear material. Any other questions while I'm doing this? Come on, Luis, you
Yes.
gotta empty this thing.
We have a viewer on Facebook who says, I had surgery many years ago and ended up with an infection and sepsis.
Oh.
After vancomycin, I have had issues with multiple drug allergies, with what I've been told is anaphylactic mast cell reactions. Could I still have this kind of surgery?
The answer, yes, you can still have this kind of surgery. Absolutely. If you have allergic reactions to medications, we're not going to give you any of those medications. We don't want you to have an allergic reaction. So we would just need to know what medications you're allergic to. This is the tear, by the way, you see it? So we don't ever give patients medicine they're allergic to intentionally. We've never done that. I don't think we've ever given any patient any medicine they're allergic to. We've not had an anaphylactic reaction here, which is good and maybe a little bit lucky. But, you know, we're very thorough in our history, getting a history from the patient and doing everything properly and labeling and, you know, armbands and things like that. We do everything you're supposed to do. So we've fortunately never had an anaphylactic reaction. And we would never give you one of the medicines you're allergic to as long as you tell us what you're allergic to. I mean, obviously, we don't actually, you know, want to know the truth? We don't do a lot of medication anyway. These surgeries are not like fusion surgeries where you need lots of medications. You get propofol. You may get a little anxiety medicine, you know, like some Versed maybe, right? And you may get a little fentanyl for pain. Huh? Ansef? Well, of course there's the antibiotic, but we don't even have to do an antibiotic if you're allergic. If you're allergic to Ansef, typically we'll do clindamycin. Okay? And if you're allergic to both of those, if you're allergic to every antibiotic in the world, truth is we don't have to do any antibiotic. We can do it without antibiotics. Your chance of getting an infection is extremely low, probably less than 1 in 500 or 1,000. So we could do it without antibiotics at all, not a problem. I hope that answered your question. It's a good question. The yellow stuff is just some fat that I pushed in from the foramen when I went into the disc. No big deal. Little adipocytes, little adipose cells. Nothing to be alarmed about. Happens if you have fat in your foramen, which most people have fat in their foramen. Anybody know why? Energy, yeah, of course. So what needs energy in the foramen? The nerve. Nerves use a lot of energy. I think we're done. Yeah, remember what nerve, what part of the nerve is in the foramen? Anybody know? That uses so much energy, huh? Well, you need cells to use energy. You said the medial branch? That's a good guess. I like it. That's intelligent. You know the medial branch is near the foramen. It comes out of the foramen. It's the dorsal root ganglion. The dorsal root ganglion is a ganglion. It's a collection of nerve cells, bodies, that are part of the sensory system. And as a matter of fact, it's the dorsal root ganglion that probably is chemically irritated to cause the leg pain that people get when they get a chemical sciatica, like a irritation of the sciatic nerve. It's the dorsal root ganglion that's being irritated in the foramen by the herniation. So anyway, your dorsal root ganglion needs lots of energy, consumes lots of energy. Now, what? All right. Now it's interesting, the central nervous system itself doesn't use fat for energy. Okay, but the dorsal root ganglia is not part, take this, not part of your central nervous system. The brain and the spinal cord are. Just take it. So the brain never uses fat for energy, it only uses glucose, sugar. And the spinal cord only uses sugar. But the dorsal root ganglion is not part of, it's not part of your central nervous system. So anyway, just interesting facts. All right, we're done with 2 discs. We're going on number 3. We've done 4-5 and 5-1. Now we're going to do L3-4. Go ahead, move it. So remember, we already placed the spinal needles through the foramen into the disc, through the annular tear. And so I don't need the patient awake for any of this. I'm just putting pressure on his paraspinous muscles. I don't want an intramuscular hematoma. All right? If I don't do this, he probably won't get an intramuscular hematoma anyway. But probably about 1 in 20 patients will have some bleeding that gets into the muscle, along the track, into the muscle, and then that can cause a lot of muscle spasms and pain after surgery. I had one patient who I did this surgery for. He worked on a cruise ship and was an entertainer, and I'll never forget, he had, I didn't put the pressure, and I think the anesthesiologist for that case let the blood pressure go up too high, and he ended up with a small intramuscular hematoma, which it took about a month to go away, but during that whole month the guy had muscle spasms, because as the blood clot breaks down, it irritates the muscle. It causes an inflammatory reaction. Blood is inflammatory, pro-inflammatory. Hemosiderin is pro-inflammatory. So the patient, say guy, but the patient, he was a guy, he ended up with muscle spasms for about, like I said, about a month, and there was nothing I could do about it. So ever since then, I learned my lesson, and I always put pressure on the muscles, because it's that 4 minutes of pressure for the patient could save them from a month of pain and suffering. Alrighty, we're going to go to the next disc up, which is the 3-4, and then we'll finish. The last one will be L2-3. Okay? We ready? Alrighty. Let's see. Shot? So I've got my guide wire in. I'm removing the needle. I don't want to take the guide wire out. If you accidentally pull the guide wire out, you must start over. And for that, you need the patient awake. So don't ever just try to put the guide wire back without waking the patient up. You will be most disappointed if you create a problem for the patient. That would be very careless. I know I make these surgeries look easy, but that's because every little thing I do is done over 1,000 times. It's kind of like driving a Formula One race car. Lewis Hamilton doesn't sit there and think about, okay, turn this, turn that, do this. It just happens. They call it muscle memory, but it's really the cerebellum, the small brain, that controls all those pre-programmed motor movements, learned motor movements. So it's my cerebellum working. I could be having a conversation with you, the viewers. I could be eating a slice of pepperoni pizza and still do this without really thinking consciously about it. It just happens at a subconscious level. Let me just see for a moment. There is a little bit of conscious level thinking. Why is it so blurry? Get another shot. Yeah, if you hold the button too long, then it collects motion. I think I want to put it in a little more before I take the guide wire out. You got to make sure the tip of the dilator is safely inside the disc. This inside out technique, as I've told you before, the viewers, well, I learned from Dr. Anthony Young. That was his discovery. You should see these guys go at it at meetings. The inside outers versus the outside inners. Whew. They argue about such petty little things, you know, for hours. They hate each other over it. What I'm referring to is should this tube that I'm about to start the surgery with in this disc, should it start it inside the disc or outside the disc? And the answer is you want to start inside the disc. That's what I do. And I've tried it both ways. And the outside to in is dangerous, in my opinion. It's unsafe shot. Should never be done. But there is doctors who do it. Mostly in England. Shot. There is a doctor, I should say. Dr. Knight. And he's a outside in guy. Whereas the one who taught me shot is inside out. Which is safer. Always safer for the patient. It's just better. And I'm not going to tell you all the reasons because that's part of my secret sauce. But it's if you want to do this surgery the best way possible, you go inside out. You start inside the disc and pull your way back out and zap the herniation that way. Okay, we got this disc and one more to go. We're doing 4 herniated discs today. The whole lumbar spine minus L1-2. Any questions?
None others currently.
Okay, I appreciate the questions, by the way. It gives me something to talk about. Otherwise, I'll start talking about other weird things, which you may not have any interest in, right? Like pepperoni pizza, because it's close to lunch.
It's like the 4th time you brought.
Uh-huh.
It's like the 4th time you brought up pizza.
Is that right? I talk about pizza that much?
In this case.
It's okay. I can accept that. That's who I am.
Pepperoni your favorite?
Pepperoni? It's either pepperoni or Hawaiian. Then again, if you get a really good meatball and ricotta, oh man. There's just something so satisfying about pepperoni though, isn't there? I like the Italians. They make spicy pepperoni pizzas. Those are my favorite. All right, so we are at L3-4 and we are in the annular tear and the herniation. This is part of the what's called the interposed herniation. The interposed herniation is the herniation that's stuck between the annular fibers. Remember, the annulus of the disc, the containment wall, is about a centimeter, and maybe not a centimeter, maybe half a centimeter thick. Okay? And it's made out of collagen. Same thing scar tissue is made out of. Collagen, elastin, some fibrin. And the tear that allows the jelly to squeeze out in the annulus, the annular tear, has jelly, like piece right there. You see that blue piece? That's wedged into the tear. And it's not allowing the annulus to come back together and heal with collagen. So what I got to do is I got to get these fragments of interposed nucleus pulposus that are wedged into the annular tear. I got to get them out. Stand by. So that the annulus will heal. The whole concept of the annular tear healing is foreign to most doctors. They don't understand it. And it's funny because as surgeons, you think surgery to fix people. You always think the surgeon's fixing the problem during the surgery. But people don't really think about the fact that some of the benefit of the surgery happens after the patient goes home. For example, in spinal fusion, the fusion itself never takes place in the hospital. It takes place over the next 4 to 6 weeks, even 3 months in some people, as the bone itself grows together. That doesn't happen during surgery. It doesn't happen immediately after surgery. It happens weeks and months after fusion surgery. So a spinal fusion surgery is really a misnomer, because the fusion doesn't take place during the surgery. It takes place after, about a month after. And it's a process. It's continuous, okay? It happens. It's like running a marathon. When you cross the finish line, that's not when the marathon started. It started, a long time before that. And it was a process of running across the course, that took time. And then you finish. The finish is just the finish. The fusion is the end goal. For spinal fusion, it happens gradually, like a marathon run. So the same thing with the Duke laser disc repair. I am removing what's causing the inflammation, which is the herniation, the nuclear material stuck in the annulus. I'm removing it and cleaning up the annular tear so that it can properly heal itself. But it's the actual annular healing that takes a full year to heal completely. That annular healing is what prevents another herniation from happening. Okay? And if you don't let it heal properly, you do too much too soon, the annulus won't heal properly. You'll get another wedged in herniation called an interposed herniation, and the disc won't heal properly. Okay? So to get your disc to heal properly, you have to restrict activities after surgery like this to lifting and bending, no lifting and bending, no contact sports for a period of time. And that period of time depends on how many discs you're getting fixed, how bad the discs were, and whether you smoke or not, because smoking slows down healing. What your nutritional status is, because poor nutritional status equals delays in healing, longer healing periods of time. Okay? So nutrition, nicotine, tobacco use, vaping, whatever. There's a piece of herniation, again, stuck in the annular tear. That's blue because it's nucleus. Only degenerated nucleus stains blue with my stain. This is the Duke Spine blue, by the way. It's a royal blue. It's a beautiful color, just like Duke Spine Institute's colors. Okay?
We have another question.
Sure.
So a viewer from YouTube says, I have mild stenosis identified on my MRI, and my surgeon doesn't want to treat me surgically. However, my radiculopathy is very severe.
Yes. Yes. You are. Thank you, viewer. What's the name of our viewer?
Andrew.
Andrew. Andrew, thank you. You have proven my point. And Andrew, your story I've heard a million times over in just the last 10 years. Honestly, it's so common, your problem. The problem, Andrew, is you have a herniated disc that's small, and it's causing mild stenosis, and you're having symptoms. But you see, your symptoms are not coming from your nerve being crushed, and that's what the surgeon's looking for. A giant herniation crushing your nerve, and then they'll operate. Your symptoms are coming from irritation of the nerve, not crushing the nerve, but irritation. It's a chemical irritation from inflammation. Your body is inflamed right in that disc. Right in that annular tear, you have inflammation going on from the tear and the nuclear material. That's why you're having your symptoms. Your surgeon doesn't understand that. Your surgeon was never taught that. That's what I had to learn by studying patients and their outcomes. So you won't find surgeons that are willing to operate on that to make you better, except here at Duke Spine Institute. My advice to you is save up your money and fly to Florida, wherever you are. Come here and get it fixed. We will fix it for you. We do offer free MRI review. So if you're watching right now, or you know somebody with back pain or neck pain, go to dukespine.com, this D-E-U-K spine.com, and we have a free MRI review option. You basically upload your MRI images and the report. We look at the images, the pictures, and the report, and we figure out where your pain's coming from, or your leg pain, your back pain, your neck pain, your arm pain, thoracic pain, wherever you're having your symptoms. We'll look at the MRI, and then we'll do what's called a telemedicine conference with you, where our doctor can actually examine you over the internet through video and audio and figure out which of those things on your MRI, those herniations or bulges or whatever, which ones are causing your symptoms. And then we can fix it, okay? But for us to be able to tell you which disc is causing your problems, we need to actually see the MRI. All right, and then we can tell you. So your pain is coming from that small disc herniation. Your surgeon doesn't know what to do about it. If your surgeon knows how to do a fusion would work. It would take your pain away. But why would you want to go through that kind of a major surgery when it could be repaired naturally with a laser like we're doing right now? So you wouldn't. That's the answer. You don't want to. Your surgeon probably won't even offer you a fusion. Most surgeons don't offer fusion unless they see a lot of deformity, like slipping of one bone on the other, called spondylolisthesis, or scoliosis, or kyphosis. These are deformities, different types of deformity of the spine. So you may not have those. Your surgeon doesn't want to operate on you because of that, but you're going to end up suffering with pain the rest of your life because your surgeon is frankly being an idiot, okay? They're too dogmatic. You understand? They believe in something that is wrong and false. That's how they were trained. And it's pervasive in the field. And they just can't think outside the box to understand why you're having pain. And they don't understand that they could actually fix your pain. They wouldn't believe it if I told them. If I told your surgeon that I could fix your pain, they would think that I was absolutely crazy. Why? Because this technique you're watching is so new to these surgeons. They've never seen it. Most of them have never seen it. Okay? And they have no idea it even exists. So they can't offer it to you because they don't know how to do it. They don't even know it exists. They don't understand anything about it. It's so foreign to them. You understand? So you, like many, many, many millions of people, are in the same boat. You got a problem that's fixable, but your doctors can't fix it. They don't even know it can be fixed. That's the sad truth. And now you understand why Duke Spine Institute broadcasts our surgeries live. It's not for you to watch a fun video. It's for you to learn that your problem is fixable. It's curable, but you got to go to the right place to have it done. Okay? It's just like fishing, guys and gals. If I want to catch a giant tuna, I need to go where the tuna are. I can't go to the retention pond in the back of my house. If I go to the retention pond in the back of my house, I will not catch a bluefin tuna. If you want to get rid of your back and neck pain, you got to travel to Duke Spine Institute. We'll do it. But where you are, you won't find it. Just like you won't find a giant bluefin tuna in your retention pond. And if you keep looking in the retention pond for a bluefin tuna, then you're crazy, and we don't want you as a patient. So just stay there. I'm being mean, but I'm serious. It's really at that level that people are difficult sometimes for them to believe and understand the truth. You have any other questions, Sean?
That's all for now.
All right, we're just about done here at L3-4. So we've done now repairs at L5-S1. That was the first disc. And then L4-5, and now L3-4. And then we're going to go to L2-3. And I showed you the MRI at the beginning of the surgery so you all could see it. and understand what the MRI showed. It showed basically what are called bulging discs or herniated discs at L2-3, 3-4, 4-5, 5-1. He also had a herniated disc at L1-2. It was very small. I don't think it's contributing to his symptoms. I'm leaving it alone. There's no reason to treat a herniated disc that doesn't cause pain or neurological deficits. Yes? She cannot go home. I'm almost done. Yeah. So the first patient we did wants to go home. She's feeling great. She's ready to leave. But I'm not ready for her to leave until I get to see her. So just tell her another 10 minutes, I'll be there. All right? How is she doing? How is she doing? Uh-huh. All right. She got Robaxin. Good. Huh? 10:45. What time do we have her out of the OR? Why didn't we give her Robaxin during the surgery? We have IV Robaxin, right? Did we not give her any Robaxin during the surgery? Huh? Huh? No? Yeah, I think next time we should be doing that. I would say yes, all of them. You should take a look at Santiago's protocol. Luis, get Santiago's, some of his anesthesia records and review it with him. When does he give Robaxin? I'm pretty sure he gave it during the surgery, right?
I believe so, sir. Yes, sir. I will, yeah, I will get out.
Yeah, that way they wake up, they don't have muscle spasms. Rather than, everyone's going to have muscle spasms. We went through their muscle. And in the neck, they get secondary muscle spasms from the surgery. So we need to anticipate that a little better. And, you know, administer. Santiago did a whole year here. He really mastered the anesthesia side to where the patients were just, it was amazing. They were so comfortable post-op, you know. I would really encourage you to look at what he did. All right, just about done. These are the last. This is the outside of the annular tear right here. It's literally just about finished. And we'll be moving on to the last disc. So we need about 10 minutes left. This was a bad tear. This is, of all the tears of the disc so far, this is the worst, right? I mean, it's huge. Huge tear, big herniation, and this will heal nicely now that we've cleaned things up. What is it? You don't have it there? Well, if it's not, we'll get you some, no problem. Any questions?
None others.
Luis, I want to hear from you later today. You review that Santiago record and let me know. Or call him and find out. I don't like having to reinvent the wheel every time we do a new anesthesiologist. We need to really be more instructive.
Yes, sir.
All right. There it is, the epidural space. The nerve root's going to be up there in the fat. And I'm just going to clean this up right here. A little piece of herniation. Laser's amazing, huh? How precise it is. Just under the nerve root here, making sure I don't leave anything to push on the nerve root or irritate the nerve root. Laser off. That's the foramen, folks. We're in the foramen there. When you talk about Uh, outside in technique, that's what we're referring to. Scope off.
Thank you.
So that was L3-4. And now we're going to do the last level. What do you think? Did you find it?
Go down. Can you check the machine? Check my shoulder. What is it?
Let me know when you're ready. You ready? Shot. Let's go up a little bit north, just a little bit, and see that 2-3 better. That's good. I like that. All right, you're pulsing, right? Perfect. Okay. Shot. Perfect. Shot. That's it right there. Good. Shot. Shot. So when I say shot, what I'm saying is take a shot. Shot means a picture, in case you're wondering. It's an old terminology. Shot. Let's see. So this one is a little tougher because the way the bones are, they're kind of sliding a little bit, and so they're offset. No, I don't want any shot. That looks pretty good. Shot. Yeah. Shot. Okay, that's good. We're making some progress here. So it's the bones are a little bit offset, and we call that a listhesis, spondylolisthesis. Now we're not doing any spondylolisthesis surgery here because I don't think it's necessary. We're shot. Let's see. We're just going to repair the disc. That's all. We're not fusing or correcting the listhesis. Shot. Take it. Just leave it. Take it. All right. Shot. Yeah. So, a lot of doctors would fuse if they see a listhesis, but it's unnecessary if you're treating pain or even nerves that are getting pinched, okay? Because it can all be done with the surgery, the laser endoscopic surgery. Shot. You don't have to do a fusion, and people don't want fusion They would rather fix their problem without fusion. Shot? Yeah. Take. Whenever possible. Remember, this disc was a 9 out of 10. It looks good. That's it. Let's move the fluoro out. So for his surgery, because he was 4 discs, we couldn't do it all with one cut. We had to do 2. And the reason is I just couldn't get to the last disc through the first incision where the other ones were done. And the reason was the incline, the angle. It brought me to the transverse process, and I really needed to be in the foramen. I don't see my mark. Where's my mark? Do you see the mark? Is that it?
Yes, sir. Yes, sir.
Okay, very good. So this is our last disc that we'll be fixing today on this patient, and hopefully the last disc he'll ever need fixed. All right, that's fine. Thank you. So we're inside the disc, and as I said, this is the L2-3. Thank you. We know it hurts him because we tested it about an hour ago. We tested it, and it was painful. Sir, we need about 10 minutes.
This is the specimen. Yeah, sure.
Oh, perfect. Yeah. Yeah, that's good. That's good. So please let my other patient know I'll be out there shortly to see her. So, yeah. All right. So there's a lot of nuclear herniation material there that I shoved back in. And I'm going to try to remove it this way because it's better if I can grab it out. And come on. I always put the end right where the same place every time. Your hand should be ready for it. You understand? Oh, it's a big one. Wonder if it got stuck in there.
We have a question.
Sure.
This is one we get asked a lot, but Dr. Duke, why did you choose spine surgery instead of doing brains?
Oh, that's a great question. Why would I choose spine surgery instead of doing brains? That's a great question. I am a couple of reasons. So, most importantly, God took me in this direction, okay? And God has guided me to do what I do. And that's number one. Number two, there's a need for this. There's not much need for brains because there's so many neurosurgeons that do brain surgery. And they do it well. You know, they do a good job. Our understanding of brains is more advanced, I think, than spine problems. And there's a lot of neurosurgeons that do good brain surgery. They specialize. There's so many that are specialized in all the different things that happen in the brain, like aneurysms or tumors or hydrocephalus or things like that. So I thought about doing brains like epilepsy, but what happened was, as a matter of fact, I think I talked about this before. When I first went into neurosurgery, I was going to be a pediatric neurosurgeon. I was going to operate on children with brain tumors and save them. That was my goal. And, you know, unfortunately, that was not my calling ultimately. I think pediatric neurosurgeons like Ben Carson are very very special people. And when you're a pediatric neurosurgeon, you spend a lot of time talking to the parents. And I realized that I'm just not much of a sit down and talk kind of guy. Some of the people that come visit me may be surprised when they come, because I don't like to talk too much. I'm more of a man of action. That's my personality. So when I have super chatty patients sometimes, they're not happy with me. So sitting down and chatting about problems is not my forte. And as a pediatric neurosurgeon, that's what you do a lot of. I learned that because I did pediatric neurosurgery for years. It's part of our program, part of our training. So I realized it just wasn't for me. So I got interested then in epilepsy and functional neurosurgery, basically the function of the brain. Rather than just going in and clipping aneurysms and taking out tumors, I got interested in the way the brain works, how it functions, and how you can improve memory, how you could improve performance of the brain surgically. And I did an NIH, as a principal investigator, I was awarded for NIH grant with Dr. Steve Roper, my mentor, and I studied epilepsy, basically neuronal function. Neurons and groups of neurons and how they worked, and how the condition of epileptic seizures affected them. So I did that for several years in many different ways. I did that at UC San Diego with Lou Cornacchia, another mentor of mine back in my undergraduate days before I started med school. So I had an interest in epilepsy, an interest in functional neurosurgery. And then as I was kind of doing my fellowship in epilepsy and functional neurosurgery with Dr. Roper, I had to cover some spine surgeries with some of our spine attendings, and one of them in particular really turned me on to spine. I told you earlier his name was Jeff Henn, and Jeff was doing things I'd never seen done before by any of my other attendings, and he was having really good results with the patients, curing back pain. And curing back pain is not something that neurosurgeons or neurosurgery residencies emphasize or strive for. It's like on a list of 300 of the top things neurosurgeons do and care about, curing back pain and neck pain is like number 300 for most neurosurgeons. They don't care about it. They don't pay attention to it. And yet they're spine surgeons. So it started to really get interesting for me looking at spine and how successful spine surgery could be at curing pain. This was like really when fusions, real fusions, good fusions like T-lifts, when they were becoming popular, when they were becoming more evolved. Prior to that, there was onlay fusions, which don't work. There was A-lifts going through the front, which caused a lot of pain for the patient and dysfunction, and they were just horribly messy surgeries, and they were really reserved not for pain but for neurological compromise, like the nerves being compromised. And so I didn't really enjoy A-lifts, which I was exposed to early, but when Jeff Henn showed up and started doing these really advanced surgeries to cure pain that he learned at the Barrow Neurological Institute with Sontag and Dickman, that's when I started to see impressive results, and I wanted to be a part of that. I like improving people's function. That's why I was interested in functional neurosurgery, but I didn't realize that I would gravitate towards like spine function rather than brain function. What's ironic about it is these surgeries you're watching me do on the spine, they actually have 100%. Look at that herniation. You guys want to see this? Sean, can you see it? Get some light on here.
Lights on, please.
Let's go. I don't want it on the crack. I want it on the white flat part. Right here. Right here. Can you see this, Sean?
Yes, we can.
Pretty cool. Yeah. That's a piece of herniation. Here you go. You got it? All right. So what I do surgically here with these patients is I do improve brain function. That's what's remarkable about it. Without operating on the brain. Huh? Think about that. As a neurosurgeon, I'm improving brain function without operating on the brain. How is that possible? Because pain from the back or neck takes control of people's lives. Their personalities change. They get depressed, they get anxious. Their whole persona, their whole function of their life is compromised massively. And not just them, but also the people that care about them and love them, like their spouses or their children. And they lose dignity by not being able to be a human and do things normal, by sitting on the couch all the time. Well, humans are made to work. We're built to work. We've evolved to work. Whether it's hunting or fishing or building, we work. And working gives us a sense of purpose. So it allows you to integrate into society, fit into society socially. And when someone's back or neck are hurting so bad whenever they do things that they're incapacitated, well, then they don't fit in, do they? And it affects everything about their life. So I'm like a neurosurgeon who fixes people's brains without actually operating on their brains. So it's funny you asked that question. I never thought about that. You kind of opened my eyes. I've had an epiphany. I like having epiphanies. If you're open-minded, you can have an epiphany. So I do love operating on the brain, don't get me wrong. But this is God's calling for my life. And here I am. I don't say no to God. And I recommend you don't either. After all, what are we without our beliefs? This is it. 5 minutes max, and we're done. This is the end of the last disc herniation. This is L2-3. This was 9 out of 10 in pain. And I've got 1 minute left. Doctor, you hear me?
Yes.
We'll be done. That's a little bone spur there, right there. I don't want to deal with that. It's not doing anything. Just want to leave it alone. That's that listhesis area I was talking about. All right, 10 seconds. Let me just flip this around and look the other way. Looks good laterally. Just zap that a little bit. Oh yeah, baby. We're done. Hopefully nothing comes out of there big. It's just a little nuclear material. That's the end plates, by the way, in case you're wondering. Got a nice view of them right now. That pink right there is the end plate of L2, and on my right is going to be the end plate of 3. And we're pretty much done. Well, I expect him to do quite well. The pain that he had before surgery will be gone. His chronic back pain, and yours too, if you want it to be. All right, tube's coming out. Let's take a look. Sean, you're with me? Let me have that tube.
Yes, I am.
So the whole surgery, folks, needs some lubrication. The whole surgery has been done through a tube, a metal tube. It's called a tubular retractor, okay? And this is all FDA approved. This comes from Germany. And it's really a very special design. I can't take credit for it. It was designed by people much smarter than me. But that's how we do the surgery, and we put the scope right down through that. It's a single port. Some endoscopic surgeries are done with 2 or 3 ports. Ports are the holes and channels that they work through, but we do it through 1 port. And take a look at his incision. We have 1 incision here, 7 millimeters, and another one that's about 8 millimeters. So we're going to put pressure on the muscles, get those closed up, and we'll get this patient out of here. Good work, everybody. Hopefully you enjoyed the surgery. If you have questions, folks, type them up. I'll answer them for you. We've had some, I've got a Ray Tech off the field. We've got really good questions today. And we're going to do one more surgery. It's a single level laser surgery on a patient. I believe it's L4-5. That's next. Our schedule is starting to get busy as people are starting to fly in from other countries as the travel restrictions are being lifted. I'm going to call the EBL 10 mil. No complications. And Sean, I'll be there in a few minutes.
All right, everyone, thank you for joining us for the post-op Q&A. Coming up shortly, Dr. Duke's going to be joining us at the table here. We're going to switch to his face cam. He'll tell you a little bit more about the surgery you just watched. We have a couple questions in the chat currently, but if you have any questions remaining, please type them up now. You'll see them appear on the screen, and we'll answer them in the order they're received.
Okay, Dr. Duke here. Thanks, Sean. And we have just finished up a Duke laser disc repair endoscopic surgery of the spine and the lower back called lumbar spine. Our patient had 4 disc herniations, and all 4 of them were painful. And I actually wrote out on his back the pain level for each disc. I think the least painful one was the bottom one, L2-S1. Typically L2-S1 is the most painful, but in this case it was the least painful. Still painful. It gave him 7 out of 10 pain, and that is, he said, his typical pain. Now, most people, when they have back pain from a herniated disc, it's usually just in a small area, like about this big of an area, that the pain emanates from. Of course, it can spread to muscles and cause muscle spasms, which then would make the pain feel like it's coming over a much larger area. So his pain, though, without the muscle spasms, in clinic, he pointed to L2-3, L3-4, L4-5, and L5-S1. When I looked at his MRI, it correlated with 4 disc herniations, the 4 that we fixed today. So I was fairly confident going into surgery that this patient actually was a bit of an anomaly in that he had 4 herniations and all 4 of them were causing pain. I confirmed that with the discogram. So we repaired all 4 discs, and surgery went well. We lost about 10 milliliters of blood, which is a tiny amount of blood. And the patient's going to go home in about 30 minutes. So we'll see if we can go visit him. Our first surgery went well. The patient was a 2-level cervical, and she's already gone. She's doing well. She has a little bit of pain in her neck from the surgery itself with associated muscle spasms, but she's otherwise doing fantastic. She'll be here tomorrow. She may let us interview her in clinic. She is, I can't say too much obviously, but the wife of a physician, a doctor, and they did not want to have a fusion done, okay? Now the patient we just finished up, he didn't want a fusion either. And this is kind of what a fusion looks like in the lower back. You see those screws and rods? So this patient we just finished didn't want a big fusion, and he instead wanted to have his disc repaired and preserve his motion. And that's what we just did. So we'll take our first question.
So we have a viewer from YouTube wondering, can chemical inflammation of the nerves be treated non-surgically with medications like anti-inflammatories?
Hey, great question. I love the fact that we're educating people. They're starting to understand the disease process and asking, of course, very intelligent and insightful questions. They're stimulating even me to think. So, can chemical irritation caused by the annular tear with the interposed nuclear material, which is causing inflammation, can that chemical inflammation that gets on the nerve that causes radicular symptoms, like down the leg, can that get better without surgery if you just treat with the right medication? The answer is yes, you are correct. Give this person a prize. Have you ever heard of something called an epidural steroid injection? An epidural steroid injection is where we go in and put a needle into the spine and inject anti-inflammatory medicine called steroids. Steroids are the most powerful anti-inflammatories we have in medicine. And an epidural steroid injection is putting the most powerful anti-inflammatory liquid medicine right where the nerve is getting irritated. So, epidural steroid injections are designed to eliminate inflammation. And that's why they work so well, but they just don't last. That's the problem. And so, if you think about it, patients with nerves that are getting pinched by a herniated disc, if you don't mind, Sean. Yeah. So if a patient has a herniated disc and the nerve is getting crushed, like this one here, why would an epidural medicine help that, alleviate the symptoms? The answer is it doesn't. And the reason it wouldn't is because the nerve is being crushed. Steroids don't take the crush away. Steroids only take the chemical irritation of the nerve away. And that's why epidural steroids are so effective, is because they actually are reducing the inflammation and irritation of the nerve root. The problem is they wear off, and then the pain's back. So when patients get epidural injections in the neck or the thoracic or the lower back, which we perform here at Duke Spine Institute, they do get relief of their back and neck pain and their leg pain and their arm symptoms, but it doesn't last. Now, the alternative would be to take medicines by mouth. Those are the worst option. They're going to chew up your stomach, kill your kidneys, and increase your risk of stroke. You don't want to do that. Get the problem fixed surgically. It's a surgical fix problem today in 2021 and probably in the foreseeable future. Someday there may be an alternative treatment that doesn't involve surgery, but right now surgery is the way to go. And the surgery is the Duke laser disc repair. Next question. That was our only question. All right. Well, thank you. For those of you wondering what it's like, what am I doing in there? This is a good demonstration. You can see. Let me have a. Sorry. Let me get a toothpick. You can see that this is the back of a disc. This is what it normally looks like back here. And here you have this red blob. That's the herniation. It was in here. It squeezed out through a tear. And then, of course, my laser surgery, I come in. First, I put a needle through the foramen into the herniation and the annular tear. And then I bring my instrument over that, go through the herniation, and then I use the laser to kind of zap away the herniation as I come out. So I'm removing it from the inside out. That's what we just did, folks. That's the Duke laser disc repair. And we got one more surgery next. It's an L4-5. So hopefully you'll join us. Our patient is suffering with back pain, which goes to the right side. And he's here in the operating room, draped, positioned, and ready to get started. I'm sure you want to get this over with. Am I right? All right. He says he loves Duke Spine so much he could be here all day. Well, the good news is your surgery is a short one, so it's a long run for a short slide, so to speak, but with good results. Okay, are you guys ready? Let's navigate over there. And okay, so let me mosey over to the MRI scanner. That's not going to work there. They can't see that right now anyway, so you can break off. You can break off. Just don't zoom out yet, okay? We'll tell you when you can zoom out, all right? Sean?
Okay.
All right, so can everyone see the herniation right there at L4-5? That's the 5 bone, that's the 4 bone, the 3 bone, and there's a herniated disc right there with a tear in the annulus. Now this disc up here, 3-4, doesn't look so good either. That may also be a problem, but here he only wanted to do this one today. That's the 4-5 disc. And there's a good sized herniation there. Take that. Can you hear me? It's Dr. Duke Majin. All right, we're going to get started. I'm going to start by giving you some numbing medicine, all right, on your skin. You're going to feel a little poke and a burn. All right, and then it should start getting better. If you're feeling pain, I want you to say ouch. Just say ouch. Don't try to get off the bed. Don't try to move around. You're on a table. We don't want you to, come off the table, okay? So when you feel pain, say ouch, and I will give you some more medicine. If the pain shoots down your leg, say ouch, down my leg, okay? We're going to get started. I'm going to put you to sleep in a few minutes. Now, that's not a true AP because the spinous process is a little too far, I think, to my side. So bring it a little to your side. All right, we do take questions, so if the viewers want to ask a question during the surgery, you're welcome to. I need another AP. No, still need to rotate more. Oh. I guess that's better. You came to my side. That's interesting. Okay, that's fine. Is he laying flat on the bed? Luis, did you check? He looks airplaned. Have you moved? You've got to make sure the patient is flat, okay? And comfortable in that position. Otherwise, you're going to drape and they're going to move. So, all right. Just to confirm, we're going L4-5 and we're going right approach. We are on the right side and we're going to do L4-5. So that's my hand here and I'm just going to pinch you a little bit. Okay, that's my fingers pinching, and then you feel a little stick and some medicine that may burn a little bit, but it's not really burning you, it just feels like a burn. That's just your nerves. All right. You're doing great, okay? Any questions for me? All right, we're going to get started. And I'm going to put you to sleep in a few minutes, but I need your help in the very beginning, okay? Once I get to where I need to go, I'll put you to sleep. Is that uncomfortable? All right. I'll give you some more medicine. Well, you will feel it. Huh? Oh, yeah. Well, anything uncomfortable we call an ouch, but nonetheless, shot. Lateral, please. So we use x-rays to navigate to the spine, and the place I'm trying to go is the tear in the back of the disc where the herniation is. It's called an annular tear, and I'm going to just reposition this because I can already see that we hit a vein. All right, let's, there's an issue with your lateral view. I think that your side needs to come up. Let's try that. Yeah. Again. Okay, more. Shot. Uh-huh. I think that's definitely better. A little more. Just a little bit. Let's see what that does. That's pretty good. It's amazing, huh? Luis, let's go a little more.
We have a question.
I have some questions too. But yes, that looks good. Let's leave it there. Can you, yeah, that's probably as good as it's going to get. That's probably as good as it's going to get. Yes, what's your question?
We have a viewer from Periscope who's wondering, how do you decide what approach you're going to use?
How do I decide what?
What approach you're going to use?
Well, the approach is always the same. I need to go from the skin to the tear. The tear is my target. The herniation is my target. All right, I think I know where our problem may be. It may be a little bit of wag. We may need just a little bit of wag. I think we're just about a degree or two off. Just give me some wag one way or the other. So the approach, the general name for the approach is called, actually I think that's better. I think that's better. Yeah, I like that. Let's leave it there. The approach is called transforaminal, and that really describes the last part of the journey. It's just the part right where you go past the facet joint and you go from the facet joint to the disc. That's the foramen, okay? Just so you understand. Transforaminal is like trans-Siberian, transatlantic, trans-European. It means across and then whatever you say after it. So across the foramen, transforaminal, across the foramen. The neuroforamen is where the nerve comes out, okay? And transforaminal approaches are not common. Yeah, we're right near the bad area. You're going to be okay. That's perfect. You're fine. Shot. Yep. You're doing great, by the way. Sean? We're right there. Sean? Let's get an AP. So transforaminal means across the foramen. And really, to get there, you got to go past the skin, past the subcutaneous tissue, and then under that is this fascia around the muscle. And then basically, that's perfect. Let's go back to a lateral view. And then deep to the fascia, which is a thin layer. It's about as thick as your nail, thumbnail. Past that is muscle. It's all muscle. So really, most of the trip, I would say, I would say for most patients, about at least 2/3 of the distance from the skin to the disc is going to be muscle. So really, we're going through the muscle and then through the foramen. So the needle tip is in the foramen. It's at the back of the disc. It's right where we want to be. I'm in the herniation right now. And he's not happy about it. He can feel it. But the good news is I'm going to be able to put him to sleep so he can be comfortable for the rest of the surgery. But I have to do one thing first, right? We have to test. Are you comfortable? Yeah. You know what comes next? What did he say? A lot of pain. I hope. Is that your typical pain? Huh? I know it's more intense, but is the location your typical pain location? All right, good news is that pain will be gone forever after this surgery. Okay? All right. Oh, what was the number? What was the highest it went to? On a scale of 1 to 10? 9? 9 out of 10, and it was concordant. All right, sir, you get to go to sleep. When you wake up, we're done. All right? So please count from 1 to 100 out loud for me. Nice and loud. Keep counting. All right, so you can see with that injection of the dye at L4-5 that the disc filled with dye, look at how irregular the dye pattern is. It's like a pancake, a weird pancake. A normal disc that doesn't have damage that you're born with looks like a cotton ball. That does not look like a cotton ball. And then there's a massive tear. Look at the tear in the back of the disc. It looks like a safety pin, almost. It kind of arcs through the back of the disc. It looks like it's through the middle of the annulus. Anyway, that tear is where the inflammation is that's causing his back pain. Again, this was discovered at Duke Spine Institute by myself, Dr. Duke Majan, as the source of chronic back pain and neck pain. Chronic just means pain lasting more than 2 weeks. Okay, if you have pain for a day or two, you never had back pain before, you get pain for a day, you're playing football, ouch, my back hurts, goes away the next day. That's not chronic pain. That's acute pain, A-C-U-T-E, acute. Doesn't mean it's cute, like, oh, look at the cute little chihuahua. It means it's acute. In medical terms, it's short duration. Whereas subacute is like a day or 2 days out to about 2 weeks. Anything past 2 weeks, most people consider chronic. Some people say a month, and at worst, 2 months. Point is, chronic pain is pain that people have for a long time, usually more than 2 weeks. All of our patients that have surgery have had pain longer than 2 weeks. That's because most of them don't know about this surgery. They don't know that it exists, that it can be done. Anyway, so the dye leaks out of that giant tear, and then you see it almost looks like an upside down sword blade. That's actually, and it's behind the vertebral body, that's the dye that we're seeing in the epidural space around the nerve roots. And you can see there's this huge herniation in the foramen. It looks like, how do you say it? It's about halfway up the blade, and it looks like a really intense white area or clear area. That's the herniation, all right? So we're going to take the needle out, shot, leaving in the guide wire. Thank you. The guide wire is piercing through the herniation, the clear area in the back of the disc. Okay, I'm going to make my incision at 7 millimeters. The Duke laser disc repair endoscopic spine surgery is done with a stab incision it's called a stab incision. It's a 7 millimeter incision. We don't need to go bigger than 7 millimeters because the tube that I do the surgery with is 7 millimeters wide. So if you make an 8 millimeter stab, there's no point except to try to be able to move your tube at different angles to different discs. He's a bit uncomfortable, shot. He's just responding. Now, the tip of this dilator is actually touching the herniation, the back of the herniation. That's why he's responding. You can see the dye below the tip, the dye below behind L5 and S1. You don't see a herniation at L5, S1. You see the black dye is kind of smooth behind the disc. There's no herniation there. There is a herniation at the level above at 3-4. We're not doing 3-4 today. The patient chose not to. I'm not going to go into that, but all right, he's moving his arms. Yeah, we need to get him a little deeper. Now, the last surgery I did an 8 millimeter incision. Why? Because I had to treat 3 discs, so I had to adjust the direction of the tube to 3 different orientations, and you need a little more room for that. But this surgery is a single shot. You can see that I did a 7 millimeter incision. It's a millimeter longer than the width of the dilator. The dilator is 6 millimeters, and the tube that I'm going to do the surgery with is 7. Can I proceed or should I wait? Proceed or wait? Yeah. Take your time. Take your time. No rush. We've got plenty of time. I can talk forever. She's saying, yeah, yeah.
Did you eat lunch?
I ate lunch. You guys should go eat lunch if you haven't eaten lunch.
We'll come back.
Seriously, go. Luis, pizza wouldn't do you any good. It wouldn't do you any justice. You got that nice physique. Let me know when you're ready for me. I
Yeah,
like your
another
hat, by
question.
the way, with the skulls. Day of the Dead. Beautiful. Yes, Sean.
Another viewer from Periscope is wondering, how do you avoid
Do an air
dural
guitar.
punctures?
How do I avoid dural punctures? That's a great question. I avoid dural punctures because I'm very careful. Number 1, not to puncture the dura. Number 2, I am not going intralaminar. Intralaminar is another way to get to the disc. That's how most surgeons do it. They make a cut here. Can you see this? So let's do our diagram.
Stick figures.
So the disc we're fixing is right here. It's L4, L4-5. Huh? Oh, is it a bad picture? Yeah. Yeah, so this blue line is the middle of the spine, and the disc is actually more like this, okay? And that's L4-5 disc. It's actually not quite that far lateral. It's probably about that far. All right? So the herniation is really like right here. That's the herniation. We know this was a 9 out of 10 pain. You see that? You guys like that? The herniation is like right here, herniation. So we're targeting the herniation. The other way to get there is to go right here. This is how 99% of spine surgeons do it, because they don't know how to do what I do. They're doing it the old-fashioned way. And they have to take the bone out from back here to get to the herniation. And what's right there is actually the nerve root. The nerve root. It runs here. So while they're mucking around trying to get to the herniation, they have to move the nerve root over to get to the herniation. And when they do that, they tear the covering on the nerve root and cause a spinal fluid leak. So we are away from the nerve root, coming from the side. We're going to come in here, and we're going to avoid the dura. So there's no way to get a spinal. Of course you could get a spinal fluid leak if I make a mistake. You know, if I go somewhere I'm not supposed to go. But that's why I use the x-ray machine. I use the x-ray machine to guide my instruments so that I don't get a spinal fluid leak, so that I don't damage the nerve, so that I don't injure the abdominal aorta or the pelvic veins or any other structure that I shouldn't be anywhere near. Okay, the rectum, you know, my God, if I hit the rectum, it'd be bad. Okay, yeah, so there's lots of bad things that can happen with this surgery if you don't know what you're doing and you're not paying attention. Okay, so this requires a lot of experience to do this kind of surgery properly and a good surgeon. And I can tell you right now, if I took your spine surgeon where you live, any of them, take all of them, and ask them to come in here and do the surgery, they wouldn't know the first thing to do. Honest to God, they wouldn't. You know, the truth is, Sean, if I was, you know, asked to do, I don't know, a basilar apex aneurysm clipping right now, I probably wouldn't know what to do either. That's okay. I'm not supposed to know what to do. You know, yes, I'm a neurosurgeon, but that's not my specialty. And I've already accepted the fact that I don't know how to do it the best way possible. Could I get it done? Yeah, probably. Because I've been trained very well, but I would never do that. If I had a patient who needed a basilar apex aneurysm clipped or coiled, I would send that patient to the doctor that does it the best. That's what good doctors do. It's called a referral. Referrals are nothing new in medicine. It's just some doctors don't know when to refer. They don't want to refer for whatever reason. Whether it be ego, ignorance, or financial, doesn't matter. They're all bad reasons. They should not be the reason the patient doesn't get referred to the right specialist. So my specialty is degenerative conditions of the spine like herniated disc, bulging disc, stenosis, radiculopathy, myelopathy, anything related to the spine basically. And even though I'm a neurosurgeon, I would send my patient who had a brain problem, I would send most of them, unless it's an easy brain problem and they want me to do it, I would send them to a specialist who does them all the time. So you won't, your surgeon where you live doesn't know how to do this technique. They do the old-fashioned way, it's called translaminar, and that's why they get spinal fluid leaks. So it's just poor technique. All right. Here we are inside the disc herniation, and now we're gonna basically remove this thing from the inside out. There's a little piece. You have another question there, Sean? I'm inside the disc right now, inside the herniation.
I don't have any other questions.
Yeah, thank you. The herniation is interesting. The part that you see on the MRI, folks, that's sticking out into the foramen or the epidural space, that's just the tip of the herniation. It's not the whole herniation. If you just take the tip out, you're never going to fix the problem. You have to get the whole herniation out. The herniation actually begins inside the nucleus pulposus, almost the center of the disc. That's where it begins. That's where we are right now. And we're going to start removing this thing from the base up. It's kind of like an iceberg floating in the ocean. We've just drilled down to the base of the iceberg, and now we're going to start removing it from the bottom up. Of course, the analogy it only goes so far with icebergs, but you can imagine what I'm trying to get at. That is that the most of the herniation is not the tip above the water or the part that you see on the MRI sticking in the foramen. Most of the herniation is wedged into the annular tear, which is why the Duke laser disc repair's annular debridement is so important, because you're getting rid of the 90% of the herniation that a lot of surgeons just leave. If you leave that 90% there, the patient's going to end up still having back pain, still having a high risk of recurrent herniation, and needing a spinal fusion. That's why a lot of doctors do spinal fusions in the beginning, first surgery, because they work really well at fixing the main problem. As long as you do a good technique, you can have a good outcome. Good relief of pain. All right, what other questions do you have, Sean?
We have a viewer from YouTube who's wondering, how do you know when you've entered the disc space?
How do I know when I've entered the disc space? I use the x-ray machine. That picture that we were looking at with the bones and the vertebrae, I know that I've entered the disc space when I go past the back margin of the bone. It's called the posterior marginal line. Posterior marginal line. And it's basically a line that goes from one vertebrae, the back of one vertebrae connects to the back of the second vertebrae. The only time it gets a little tricky is when, of course, when you can't see it because you have a cheap x-ray machine that doesn't work, which we don't have at Duke Spine Institute. We buy the very best x-ray machines, but a lot of other surgeons don't have the best x-ray machines because the best x-ray machines are very expensive. They literally cost $180,000. And you can buy cheap x-ray machines for about $50,000 that are used at, oh, look at that herniation that just came out. Holy magnum. Take this. That thing's huge. That literally just came out of the annular tear. See if I can get it. It's wanting to float up. It's wanting to float up and out. There it is. All right. So by looking at a line between the back in the back of the vertebral body, for in this case, for example, L4 to L5, I can draw a line in the back, and I know that's where the disc is supposed to be. Obviously, the herniation is out in the foramen, so it's a little further back than that. But also, I can feel it when I push that dilator in. I can actually feel it passing through the herniation and then the annular tear. It takes a little while to get that feel, but it's not hard to feel, to be honest with you. This is all the tear right here and the interposed nuclear material. This is the base of the herniation. So I'm inside the disc, and I am removing the disc herniation, the big wide part at the bottom.
We have another question.
Yep.
One of our viewers is wondering, is the main purpose of the laser for cauterizing the wound?
No, the main purpose of laser is not cauterizing the wound. The main purpose of laser is to remove this pathological tissue. This is all pathological tissue. Pathological tissue means tissue that is causing pathology. And in this case, the pathological tissue is inflammation tissue, nucleus pulposus that's been displaced or herniated, so it's degenerated and it's being broken down by inflammation. And then, of course, the annular tear that is full of granulation tissue from chronic inflammation with neoneurulation and neovascularization. That tissue is highly sensitive to pain and pressure. Okay, it has lots of little nerve fibers. So my goal with the laser is to get rid of the tissue that's causing the pain. I can't get rid of it with any other tool. Okay, there's nothing else. Look at how the laser just zaps it away beautifully. If I try to grab it, laser off. If I try to grab it with the grabber, these are traditional surgeon's tools, like a grabber. It doesn't get rid of the annular, scarred up annular material. You see it's all still there. You see that at 12 o'clock? I can try to grab as much as I can, and the pathological tissue remains. Some of it comes, but it's really hard to get rid of it using the grabbers, which we call pituitaries. It doesn't work. So anyone that says the laser is not necessary, they just don't know what they're talking about. They've never done the surgery. absolutely got their heads shoved up their ass so far. They have no idea what they're talking about. And I hear that a lot, by the way. A lot of surgeons, they laugh and say, oh, the laser, whatever. Nonsense. They just don't know what they're doing. We're using lasers now in neurosurgery all the time. Take out brain tumors. So all the naysayers, the people that didn't, give lasers credit, they look like idiots right now because we're using lasers everywhere in medicine. We use lasers to break up kidney stones. We use lasers to treat prostate cancer. We use lasers to treat brain cancer. I mean, lasers are amazing. They're amazing. Look at that blue tube, by the way, for those of you who don't have any idea, that's 0.5 millimeter wide. The blue tube is about 1 millimeter. The laser fiber coming out the end, right there, that glass fiber is 0.5 millimeter. 0.5. So you imagine the precision and control you have with the laser fiber. It's not like any kind of other surgical instrument. It's so precise and so effective at this job with the Duke laser disc repair that this laser will be the treatment for years and years and years to come. I don't see any other tool. Now there is something called a radio frequency probe, but they suck. And the only reason I found that some surgeons use it is because they make money selling them. So I don't make money selling laser fibers. I don't make money selling any tools or instruments. I just stayed away from that because when a company gives you money to sell their tools or instruments, it means that those tools or instruments other people won't buy or use. The only way they can get you to use it is if they're paying you money to use it. That means it's not very good for the patient, usually. And unfortunately, there's a lot of that nonsense going on in healthcare, in medicine in particular. And there's a lot of spine surgeons that get paid money to put in screws and rods, that they're getting some type of a commission or some type of a deal from the company that makes it, whether it's they become an advisor or what do you call it? Not a rep, but they consultant, that's the word. They become consultants. There's so many sneaky deals going on. And in the end, the products are terrible for the patient. They don't work well, but they put them in because they're making money on putting them in. They're making money on the implants, and they're making money on the on putting them in as a surgeon. So, there's nothing wrong with making money in medicine. I believe you should make money, but you shouldn't compromise quality of what you put in a patient for money. And these guys that are making money to put in implants that they're paid to put in by the company, that's just wrong. So they're the ones who are laughing at the laser. They're not laughing now. They won't be laughing in the future either as their business dries up, because people are smart. They're going to figure it out. They don't want screws and rods and metal in their body or artificial discs in their body when they can have a repair of the disc rather than a replacement of the disc. Why would you want a disc replacement when you can repair what's there and it works perfect, much better than a replacement does? People aren't dumb, and they're going to catch on and figure it all out real quick, especially when the truth is available for them to see, like this surgery right now. You can't even compare the Duke laser disc repair to an artificial disc. An artificial disc surgery, we'd be going through his belly. We'd be moving his intestines over and hoping, oops, did we poke a hole in his colon? Oh no. He's going to be back at the hospital with fevers and sepsis and perforated bowel, and he's going to need a colostomy, and he won't be able to poop except out of a bag for months. This kind of stuff happens all the time, folks. That's why we broadcast. We want you all to know the truth. When you hear those horror stories about people having bad spine surgery outcomes, that's right, they're true. Not here at Duke Spine, we don't have those problems, but we avoid fusion whenever we can. We avoid open surgeries whenever we can. We stick to this kind of stuff, minimally invasive, because it's better for the patient. All right, just about done. I'm finishing up this tear A lot of scar tissue in here, right there. A lot of inflammation, inflammatory tissue, scar tissue. But I'm just about done. I need 5 minutes. 5 minutes. We'll be done. Maximum 5 minutes, maybe less. Look at that granulation tissue. It's pink. See it? The little pinky stuff right there? Getting it with the laser. It's gone. Those little nests of pink are what are called granulation tissue. Look them up. Granulation, Granulation tissue. Granulation tissue is early young inflammatory tissue full of nerve fibers that are unmyelinated. They're very painful when you stimulate them with inflammation, which is what we got going on here. So it all makes sense. All right. Let me just finish this. So let's have a grabber. Any other questions, Sean?
None others.
Yeah. Yeah, we decided to start broadcasting these surgeries, every one that we do, because we want people to know the truth about everything. We want people to see complications when they happen, how they're managed, how they're avoided. We want people to see these different surgical techniques. Duke Spine has published probably over 2,000 surgeries online in the last 7 years, including spinal fusions. I need the laser on. We haven't had a problem with the laser, right?
Nope, not really.
What do you think it was again?
I don't know. I think it was maybe like a safety mold for the machine, maybe with the laser fiber. I tested the machine all week, last week and
Mm-hmm.
this week, so it was working fine. I mean, they're asking for a lot of money for just come over here and don't find anything, you know. I don't know.
Yeah, thank you, Luis. Just about done. This is it, the end of the tear right there. But look at that. Just look at that. That's somewhat normal tissue right there. But look at how frayed this is. And it's right, again, it's near an end plate. You can see the end plate there. And this is just all herniated disc stuck inside the tear. So we're going to clean this up. See the dystrophic calcification, the gold stuff? And we'll be done. I got probably 2 minutes, doctor. Unless, no, huh? Yeah, this interesting case because this is a good example of not a really new herniation like recent, like in a few weeks, but this is relatively new compared to some of the really degenerated, collapsed, scarred up discs that we've seen. This is a newer type of injury. It's a lot more fluffy stuff rather than scarred up, tough scar tissue we normally see with an older herniation. So it's all going real well. Look at the pink tissue right there. You see that? Right where the laser is? That's granulation tissue. It's you get more of it on the outside, the outer rings of the annulus, because that's where there's the blood supply coming in. The outer half of the annulus. Remember, that's where the blood supply comes in. There is no blood supply to the inner half of the annulus. There's just non-stop. This is a lot of herniation here. A lot of injury damage. Thought it would be a smaller area, but remember on that discogram we did, there was a big tear. This is it. We're debriding the tear right now. That's what the Duke laser disc repair does. It's an annular debridement. It's a tear debridement, debridement of the tear in the annulus. It's all nucleus pulposus, the blue stuff. Just about done. It's a pretty nice looking disc otherwise. Got some nice tissue. Very healthy looking. Do we have any more questions?
Not at the moment.
All right.
We actually did just have a question come in.
Sure.
A viewer from Facebook is wondering, how do you know when you've gotten all of the pathological tissue out?
How do you know, the viewer is asking, Dr. Duke, how do you know when you've gotten all the pathological tissue out? Well, I always go up, I start at the base of the herniation, and I always go and follow this tear right here where I'm working. I follow the tear all the way up to, I see the epidural space. See the fat right there? So that's the epidural space. All right? So I don't go past that. And I just go to that area, and it's always worked when I do that. Okay? So did I get every gram of pathological tissue out? Probably not. But it always takes the pain away when you do this. So could I do less and get just as good results? Maybe. I don't want to find out. The way I see it is this. I am in the outer part of the annulus right now. This is the outer, where the tip of the laser is the outer annulus. That's where the most painful nerve fibers are going to be. So if I stop before this, then I run the risk the patient will still have pain after the surgery because I didn't go far enough. Okay, so that's where I go to. That's what I've done for 16 and a half years now. 16 years maybe? And it just works, you know?
We have another question.
10 seconds. Yeah.
Another viewer from Facebook is wondering, why do I keep breaking screws? Between 2 cervical fusions I've done, I've broken 7 screws.
All right. Why do I keep breaking screws with my cervical fusions? One of our viewers asking. So the most likely cause you're breaking screws is that the surgeon is not putting them in properly. And what I mean by that is it could be the screw itself, the manufacturer, or it could be the technique the surgeon used. If you don't put a big enough cage, did the surgeon use peak cages for your interbody spacer? Yes or no? Did he use cadaver bone, like a piece of fibular allograft? Fibular allograft is notorious for dissolving away, and then what happens is you get all this force on your screws, okay? And then it'll break your screws. Another option is that they use a plate that is called a static plate. A static plate does not allow the screws to toggle. You see what happens after the surgery, the ACDF, is that your spine settles. The anterior and middle column collapse. And if the screws are fixed in the plate with what's called a fixed position versus a variable position, then the screws are going to get a lot of force because they're not allowed to collapse down and move with the bone. And so they can break. So if your surgeon uses the wrong plate and uses a fixed angle plate as opposed to a variable angle plate, and you're only supposed to use fixed angle plates for trauma, like a fractured spine in a car accident or a fall. You're supposed to use variable angle plates for herniated disc and degenerated disc. 10 seconds. So if they use the wrong plate, if they use the wrong screws, if the manufacturer of the screw is like, I hate to say it, but like a cheap screw, we're done. Then those are all reasons your screws could break. If you're a smoker and you smoke a lot or use nicotine and your bones don't heal properly, that could be a reason as well. So the most common reason is poor surgical technique. The second most common would be the implants failing, whether it's because of the plate for reasons I told you, or it's the screw because they're just not manufactured well, they're cheap. Those are all possibilities. I avoid all that stuff by going with high quality implants. The problem these days is that a lot of hospitals or surgery centers, they're trying to make more profit. So what they do is they give you cheap stuff, you know? And when you get the cheap stuff, the cheap implants, they break. I hate to say that, but that's the truth. So if you want, I'd be happy to look at his work, your surgeon's work, his or her, whoever they are, and I'd be happy to look at your broken stuff, like X-ray, CAT scan, MRI, whatever you got, and I could tell you why I think it happened. We do all that service for free. Duke Spine Institute offers free MRI review, free X-ray review, free CAT scan review, free telemedicine. Why? We offer it free because we want to help people that are suffering and that need help, and not everybody can make it into our facility, so we do it over the internet. And yeah, we want to help people solve their spine problems, basically is what it comes down to. If you've not downloaded the Duke Spine Institute app, we have an app for the iPhone, we have an app for the Android. It's called Duke Spine Institute. Search your app store and download. It's free. There's no cost, and it's full of very useful information. We're going to be doing a renovation of the app soon. We've got Zach coming back, and Zach is going to work with my new marketing director, Sean Sullivan, and Sean Hanneman, and the rest of my marketing team. We're going to be making some changes and adding to the app and making it even better. Also, if you are interested, we have a spine surgery support group on Facebook. If you want to join the spine surgery support group, it's just $1 million a month. Oh, I mean, sorry, it's free. It's free. Just kidding. It's not $1 million a month. Raytech off. And you can ask questions there. You can post your MRIs, CAT scans, X-rays. You can ask questions for somebody else or yourself, and we'll answer them. Okay? It's a real nice community. We don't allow liars and cheaters and thieves in it. So, unfortunately, a lot of the Facebook groups have trolls that don't want you to get better. So when you go in there and you post something that's truthful and helpful to people, they'll delete it or bash it. For some reason, they want everybody to stay in pain. At Duke Spine Institute, we want to fix you. We want you to be out of pain. All right, we're going to go check on our last surgery and send him home. And then this patient here will probably be ready to go home in an hour. And we'll be doing some more videos tomorrow of our post-op patients and posting them on Facebook and YouTube. Have a great day. Do you have any more questions, Sean?
Not currently.
All right, we'll wrap it up. Thank you. Nice job, everybody.